Hello, I'm Dr. John Kruse, and today I'm going to be talking about cognitive behavioral therapy, or CBT, for panic. Every Tuesday, I'm going to have a live Q&A session on this YouTube channel at 2 o'clock Pacific Time, 2 p.m., 5 p.m. Eastern Standard Time, or 11 p.m. Central European Time. Feel free to join in if you have any questions about this subject or mental health topics in general. So the take-home message for today's video is panic attacks are common and everyone is susceptible to having one. Cognitive behavioral therapy is an effective way of making panic attacks end more quickly and resetting your system so they're far less likely to recur. And cognitive behavioral therapy for panic can be self-taught, but it does require lots of practice. So, what is panic? Panic, like the word manic, is often used loosely and colloquially and inaccurately. So the difference being what the term manic means someone's suffering from mania, and with panic attack, that doesn't mean they're suffering from pania, but it emphasizes that panic attacks cause great psychic pain. They are extremely distressing, extremely overwhelming. They frequently send people to the emergency room. They often get thousands of dollars of workup to rule out heart attacks, stroke, other physical bodily conditions. And part of what's terrible about panic attacks is they often leave people in what's called anticipatory anxiety, or waiting or anticipating another panic attack. And actually, anticipatory anxiety makes you more susceptible to having another panic attack. So some people can have isolated panic attacks, but often they come sort of in clusters, or the more you have them, the more likely you are to have more of them. Now, where's the dividing line between anxiety and panic attack? Some sources make it sound like panic is categorically completely separate and different than anxiety, that there's some clear dividing line, but it can get pretty blurry. So extremely high levels of normal anxiety can verge on panic. There can be different levels or severity of panic attacks themselves. So very often I have patients who say, oh my God, that was a real panic attack. I've had them before, but it was nothing like this one. So this panic is at the extreme end of anxiety, and it's often defined as unexpected. So usually you're surprised by it, it's coming out of the blue, even if there are triggers that you may identify later or even identify ahead of time. It's a severe bouts of anxiety. Usually it's fairly time limited, on the order of minutes, not hours. Subjectively, the person almost always feels a sense of impending doom, that either, oh my God, the world's just collapsing, something horrible is happening, or bodily disaster. Oh my God, I'm having a stroke, I'm having a heart attack. I had a recent patient, I must have mouth cancer. And all these can occur together. I'm losing my mind, I'm going crazy, I'm going to be locked up, but I can't control things. And also an accompanying feeling of needing to flee or leave or get out of the situation. Now, panic always includes at least some intense physical sensations, particularly chest pain or palpitations, feeling your heart is pounding or beating irregularly. Shortness of breath is classic. Gastrointestinal disturbances, so queasiness, nausea, even vomiting, feeling shaky, feeling sweaty, changes in vision, change in thinking. So every human brain comes prepackaged with a panic center. It's already installed, it's ready to go. You don't need to call the IT guy to come set it up for you. So knowing that should help decrease stigma and shame around it. I've had lots of people who, once they discovered that what they were experiencing with a panic attack, were feeling very shameful and guilty and feeling that, I should have known better, I shouldn't have gone to the ER, I should have been able to deal with it. But again, there's nothing shameful about this. This is part of human experience. This is fine to learn from it and grow from it, but don't be ashamed of it. Why is this system hardwired into the brain? So it's hardwired for real, actual emergencies. So there are situations, say you're in the wildfire district, your house, burning embers fall on your house is on fire. You don't want to use a conscious cognitive, It will take me 4 seconds to call 911, and the nearest police fire center's 6 miles away, so it'll probably take them 10 or 11 minutes to get here. And by that time, no, you need to act. You need to get out of there. You need to be, so the panic system is designed to short circuit conscious thinking, which is important, to prepare your body to get the heck out of there. So it increases heart rate, increases blood pressure, to get blood going to the big muscles of your body to flee. Again, that's why heart palpitations, rapid heart. It shuts off blood to the gastrointestinal system, because at this point in time, you don't need to be spending time on digesting. So that's why some people with panic are feeling nausea, even vomiting, sometimes losing control of bladder or bowel. And within the brain, panic is redirecting blood flow and cortical activation away from, again, higher cognitive centers. So it is actually harder to think. That's why people feel, I'm dazed, I'm shocked, I just don't know what to do or can't even think about thinking. And it can affect visual systems. So pupils dilate, become more sensitive to light. We have tunnel vision. We are focused in on one specific threat or danger and can't take in what else is going around us. So I exaggerated a little bit before when I said everyone has a panic center. It's more complicated than that. It's not just one site in the brain, and it's not even understood fully how all these pieces always interact with each other. But parts of the panic system are your amygdala, parts of the insular cortex, part of the lateral parabrachial nucleus, and the nucleus of the solitary tract. I think that's a great name for an emo band, but that's besides the point. So even though some people will tell you, oh, the amygdala, that's your panic center, there have been studies where people have, for injuries or surgical reasons, had their amygdala removed. Some of them are still able to have panic attacks. So there's not one simple finite center, but all of these working in context. And during the panic attack itself, they are triggering the sympathetic nervous system, the fight or flight system, to full-on, full-bore flow, and that's flooding your body with norepinephrine, epinephrine, body and brain. Now we know that there are genetic influences as to the sensitivity of your panic centers. So some of that is wired just by before birth by the genes you inherited. So we know some panic systems are more easily triggered than others. We also know that experience shapes the sensitivity of your panic centers. So if you've had lots of traumatic experiences, or conversely, if you had a loving, supportive environment and genetically you were more sensitive, you can actually develop more resilience, less likely to be easily triggered. And again, on the other direction, trauma or bad environmental situations can make you more sensitive, can reset the sensitivity of your panic alarm. We also know that there's some psychological traits that actually increase your likelihood for panic. So people who are inhibited, who avoid harm, who sort of hide their feelings from themselves are actually, they may think they're protecting themselves, but study after study has indicated that that actually increases your risk by not paying attention to what's going on in your insides here and here. So what's happening during panic attacks is that there are some perturbation in the system. Something is different, and your interoceptive, your nervous system that's monitoring everything that's going on with your body, is picking up. There's some change, there's something different. That could be, so conditions or in body or outside the body that make it more likely for you to experience a panic attack can be, number one, sleep deprivation. Number two, if you have a cold, if you have an illness, anything already going on with your physical condition increases the sensitivity of your interoceptive system and increases the sensitivity of the panic detection. So your body is always scanning for something different, something wrong, something bad. Certain mental health conditions, in addition to physical health conditions, anxiety, PTSD, depression, even ADHD, all increase your likelihood for triggering a panic attack. As we talked before, panic attacks tend to breed panic attacks. So what's called anticipatory anxiety. If your anxiety level is heightened because you've already had one and you're hypervigilant for triggers that may cause another one, that in itself makes you more susceptible to have your panic attack center triggered. And certainly chemical moieties, chemical entities interacting with your body. Alcohol, nicotine, caffeine, particularly decongestants can trigger sympathetic nervous system arousal. But actually anything that's new or different, the body, again, interoceptive, the parts of the body that are surveying the inside, can be more ready to trigger a false alarm when there isn't a real danger. So by definition, a panic attack is the panic system going off when you're not in a real danger. So I'm going to briefly talk about two patients I saw last week. This was highly unusual. Most years I go by with maybe one event like this a year. But I had two patients, both had high levels of ongoing anxiety to begin with. Both were sleep deprived semi-chronically. Both had a host of pain and other physical problems. Both had started brand new medications, and both of them had histories of being sensitive to medication. We can say for another topic what that means or don't mean. Both of these individuals had panic attacks. Both of them went to the ER. They were told by both their friends and their medical team that they were just having a bad medical reaction and that they would recover from it. So neither ER directly addressed the panic, which I think one is both wrong and two is bad medicine. And what alerted me to the fact that these weren't just simple bad medications, in one case the person had had some initial side effects, had actually stopped the medication 4 days earlier, still feeling anxious, and their anxiety was building up. But if this was purely a medication reaction, their medication level was dropping steadily over 4 days. It would have been pretty unusual for the medication purely indirectly to have a toxic physiologic effect 4 days after it had been stopped and levels were dropping. And the other individual, their physical symptom that they felt was in direct response to the medication was vomiting. This was actually a drug that, among its other beneficial side effects, has strong anti-nausea action. Not that any individual can't have any bad reaction to any medication, but it was so classically their other symptoms fit with panic that we explored further and revealed that panic was basically what was going on. So this highlights one point. It's often easier to see panic from the outside than from someone who's experiencing it to feel like it, because again, one of the lies that panic says is that this is absolutely real. I'm not making this up. You're not making it up, but that there's something desperately, drastically wrong with my body. And it's an important point to make that there are sometimes real physiologic problems that are dismissed by medical professionals as, oh, that's just panic. My husband a few years ago had a twisted bowel, which is an emergency, life-threatening situation. And initially, the EMTs who came to the house dismissed it as this is just some guy who's panicking. And I'd say more often the other situation is taken, that someone, particularly when they otherwise look young and healthy, they go to the emergency room and their symptoms often are interpreted, this person must really be having a stroke, or must really be having a heart attack, or must really be having something dramatically wrong with their body, rather than just having, and I shouldn't say just, rather than having a panic attack. So the cognitive behavioral approach to panic starts with saying and identifying, this is panic. This is a panic attack. And that doesn't mean, we can just dismiss it. That it means this is something real, this is something identifiable, this is something we know how to deal with, this is something that your body, that is time limited, despite what it's telling your body right now. So second point is CBT approach is saying that your body is responding to something this is real. Your interoceptive system did detect some real change. These new medications in these patients were started. there was something real. There was something different there. Their body really picked up. There was an actual trigger. We can't always identify triggers in panic, but usually we can. So again, this isn't just coming out of the blue. This isn't just your brain creating it. This is your body reacting to something that's real. The second or third element is that this isn't just, so what's going on inside with panic is your internal sensors are picking up something that's, this is weird, this is different, this is strange. And then it makes a leap from this is weird or different to this is dangerous. That's the threshold for jumping into a panic attack. And it's an overreaction, it's an inaccurate assessment. Again, we have these systems built into us for a reason. You can't build a system that's there to detect danger without it going off incorrectly, at least part of the time, as any of you who have home fire alarm systems know. So part of it is talking back and saying, no, this is not dangerous. This is weird. This is different. Your body picked up something real, but that does not make it a dangerous situation. So for getting back to what's real, the sensations you're feeling, your heart is really pounding. Your muscles are really activated. Your vision is really blurred or photosensitive. It really is harder to think right now. You're not just imagining those. These are not, even if they're happening partly in your head, that doesn't mean they are, again, imaginary. That doesn't mean they're fake. That doesn't mean they're not real. These are real things that are going on with your body, and they're part of the feedback that keeps panic going. But these are sensations that are triggered by your panic center. They are not a response to a true life or death, danger or emergency. So point number 6, I think I'm at. If this is coming from your brain can stop it. That's a really important message. This isn't forced on you by the environment. This is created by your brain. And if your brain created it, can stop it. So part of it is even if you do nothing, the intensity of a panic attack can't be sustained indefinitely. Usually it's minutes, much less than an hour. So even though it's telling you, part of the lies, the panic says, it's really bad now, but it's only getting worse. It's only getting worse. Not so. So talk back to that lie. No, this will end. If you've had panic attacks, it makes it easier. I've had them before. Horrible when you have it. You'll get through it. You'll get over it. And work to remind yourself. Even if it doesn't feel like I'm safe right now, I'm safe because I'm dealing with the panic attack. This is a normal physiologic response. I can deal with it. I can get through it. I've done it before. And a reminder that these things are easier said than done. That simple doesn't mean easy. So cognitive behavioral therapy, CBT, often breaks things down into simple principles. That doesn't mean they're easy to execute or follow or understand. That point here, human brains need lots of repetition. When you are in a panic state where you are less able to cognitively process things, it needs lots of repetition. So both individuals I was talking about, I talked when they were at lower levels of panic after their first initial episodes, and they were both mildly panicking still, and I need to go over and over, and both of them said, intellectually I get what's going on, but I just, they were apologetic for me needing to repeat it and go over with them, and I said that, this is how human brains work. They need a lot of repetition. So in terms of tools for getting out of that panic state, distraction, focusing on anything else outside, because again, the panic directs your body to be focused on one narrow little danger. If you can get out of it by using your senses, can I hear anything else that's around me? Can I look intentionally to see what else is in my world right now? And separate from using your senses is using your own body. So breathing tools are a huge part of dealing with panic. They work on 3 different levels. One, they're a distraction. As I've talked about before, our anxiety problems, including panic, are actually problems of attention. We are directing attention to the wrong thing. We're directing it to what's a distraction. We need to get back in touch with life, but again, distracting us from the distraction, anything that does that is helpful. 2, breathing tools help you regain control of your body. Part of what's going on in panic is that it feels like my body is out of control. I can't do anything with it. It's spontaneously pounding away. But if you are actively changing your breathing, that is giving you a direct message that, wait a minute, I can control, I can fight against this, I can resist some of this. And 3, there's certain breathing techniques. I have a separate video on cyclic sighing that actively activate the parasympathetic nervous system, which shuts down, damps down the sympathetic overdrive you're feeling in right now. I'm not going to get into it in too much detail, but hyperventilation, which is sometimes a tool taught to people, might serve as a distraction, might help regain a sense of control, but actually can be counterproductive. So I'd say almost any breathing which is slowing and calming is good and helpful. Again, I'm repeating it because repetition is useful, repeating messages over and over again. So with these 2 individuals, I kept reminding them the medication they took did help trigger something that was going on in their body, but the levels are declining. It's not actively controlling you right now. And there's no shame to needing that message repeated over and over. And the related concept that there's no shame in intellectually getting it but not feeling it inside. That's why you rehearse ahead. That's why you practice. That's why you repeat it often enough. It will permeate down from your intellect to your body will feel it. Part of the body holding on to it longer is that chemical aspects of emotions tend to persist longer than cognitive thought does. And part of it is that the process of panic includes a large amount of reactivation and retriggering. That if your body's going haywire, you're continually giving messages to your interoceptive system that something's off, something's bad, something's wrong. When you're out of the intensity of the immediate panic attack, it can be useful to identify triggers. It can be useful to work on making those things feel less threatening. And it can be useful to practice these techniques with lower levels of anxiety so you know that they work, rather than just waiting till there's a full-blown panic when you'll have to engage them more fully and more vigorously for it to work. Getting good sleep, avoiding certain chemicals that are triggering are valuable for reducing panic. Being in better physical conditioning, that helps in 3 different ways. 1, it gives your body the experience that your heart rate can go up, your breathing can get short, and that's okay. It's not always going to be linked to a sign of danger. 2, we know that people who are in better physical shape are more resilient to a whole host of external perturbations, including the internal external perturbation that a panic attack is. And 3, that they give someone greater sense of control over their own body, which is one of the things that gets lost in panic. Not going to talk too much about medications now, but there are some individuals who, with a serotonin reuptake inhibitor, a serotonin and norepinephrine reuptake inhibitor, they need that to create enough calmness to be able to work on cognitive behavioral therapy techniques. So some people are so distraught, fraught, overwhelmed, not in their cognitive mind, that they can't use CBT till they're calmed down. Benzodiazepines like Valium, Ativan, Klonopin, Xanax can successfully treat panic, but there's some evidence and lots of clinical opinion that they actually undermine CBT approaches, because essentially people wind up saying, yeah, I did all this talk therapy, but it was like when I took that Xanax, I saw the anxiety drop. That's what really did it. So I am not a big fan of using benzodiazepines in panic because they can undermine cognitive behavioral therapy techniques. So there is a best case, worst case scenario tied to the CBT approach for panic. So many people coming in hoping, oh my God, this technique's going to work. I'll forever and ever be rid of panics. I'll never be part of my life again. But wait a minute. We've said that intrinsically built into your brain is a panic center. We are never going to eliminate it. And again, some of the lesion studies show that even if you destroy parts of the brain, your body can still probably find ways to panic. So, but there is a reassuring message that this approach is actually to teach you that if panic occurs, you will be able to manage it. You'll be able to cut it off more quickly before it achieves much intensity. And there is much greater security in knowing you can deal with life as it comes along than thinking, okay, I flipped a magic switch and I'm always going to be safe forever after. Because if somehow something flips that switch again, you're going to be more freaked out, more undermined, more overwhelmed when it comes back. It's kind of like this silly, why we have people take their shoes off because of the shoe bomber on the airports. That doesn't make us safer. It's trying to create a false sense that we're going to treat all the past reasons something went wrong, but if something new comes up, then we're going to be freaked out. So it's much better to know we've taken reasonable precautions and we can deal with whatever comes up. So the final message is that there is good evidence that when CBT is successful, it does result in changes in neurochemistry and rewiring of the brain. It's not just talking here, that there are intimate interrelationships between talking therapies and brain physiology. So thanks for listening today. I will be answering questions about this and other topics on Tuesday. Stay healthy, stay happy, and